Hello, everybody. My name is Meinolf Suttorp. I'm a retired professor from the University of Dresden in the southeast of Germany. And I'm happy to share with you some of my experience on parenting in children with CML. I have been working for a long period of my life in the town of Kiel, where sailing was a big event. And so I want to give you some examples of the techniques you apply in sailing, but as well when talking to patients with their ill children. And what you need when talking about a disease like CML is confidence, and this confidence in a captain to reach a safe place. The harbor means you need good organization, you need techniques, and you always have to look at the future, what might happen or what will happen next. And the most important point when you emanate confidence is that you know the disease you are talking about, at least by reading, because it's just a rare disease, but the parents and the children will not. And it is different from acute leukemia, which is the most common malignancy in children. But this chronic disease has a completely different pattern of time when you cure it. And what you can do is that you document the white blood cell count at visits, and you can mark the spleen size on the body and then ask them to take a picture with their mobile phone and show to the parents week by week how the spleen becomes smaller. And there are many organizational aspects. That means you should not delay in the first week when the disease is diagnosed to talk with the parents. Otherwise, the family will seek wrong information elsewhere. And there should be multiple talk, not a single one. And you also should enforce discussion with other families who have a child with CML. That might be far away, but it can be done by telephone. And from my experience, that is very helpful. The techniques are most important that the talk with the family is not extended beyond 1 hour. Then usually these parents cannot follow you anymore. And you should use illustrative examples from the experience of a patient. So if you work in a town besides the sea, you can use these pictures from sailing, but there may be other examples where the patients immediately get an insight in the idea, what you mean. If topics are not relevant at the moment, for example, stopping the treatment in CML, you should postpone it. But you always should promise to talk about it at a later time point. And key messages like taking the pills every day must be repeated on different occasions always. A look to the future means you should do this as early as possible. The regular intake of tablets is most important. The information on side effects which might arise is important. And you also should address pregnancy in girls at pre-pubertal age, because these girls have a certain role model and they may dream of becoming a mother and having their own family. And the aim of the treatment in CML to have a life as close as possible to normal. There are obstacles when treating a chronic disease and when talking to patients. And I've divided this into 4 major obstacles. The patient is number 1, then the social and political conditions, the relationship between patients and physician, and the treatment itself. And we are now going to run through these topics one after the other. The pediatric patients, of course, have different ages. CML has a median age of 12 years, but there may be very young children, 4 years, and there may be older teenagers of 17 to 18 years. And they all have a missing knowledge on the disease because it's so rare. And that also implies that they have to comprehend the therapy, which is different from other leukemias. And they must understand how the treatment is working. And if the father or mother of the child works in a factory, it might be helpful to compare cellular functions with this factory, e.g. that the management is important for organization of the whole workflow, that there are vesicles in the cell, which are equivalent to storage tanks where the products are stored, that there are pores, the gateways where the traffic in and out of the cell is regulated, and so on. So in certain situations, such comparisons may be very helpful, and you may have other comparisons. And it was very helpful during my work that I stored some pictures like these and used them when talking to the patients for explanations. Another very important point is that the response to treatment concerning the reduction in the spleen size and the reduction in the white cell count is rather slow compared to acute leukemias. There is no day 8 less than 1,000 blasts in CML or day 15 remission in AML. See these two examples here, more than 10 years ago when I treated a patient, it took about 4 weeks until a normal white cell count was reached, and 2 weeks to half the white cell count. So CML is a leukemia, but definitely it's not like ALL or AML. When you look at the patients at different ages, there might be developmental crises and power struggles. The child's own will at preschool age, where they refuse to take tablets, or the autonomy in teenagers, where they want to take the pills by their own, but and sometimes they may forget it, and this is a threat, as I'm going to show you in the next slides. But you all know that puberty is a problematic age. This slide here was given to me by my colleague who treats diabetic patients, and you see the HbA1c level is perfect at prepubertal age when the parents care for treatment, but it becomes poorer at pubertal and postpubertal age because at this age, typically the adherence to treatment is lower. Also very important is the supply with the drug. There's a big study from Korea with almost 3,000 adult patients. And in Korea, the National Health Insurance pays for the drugs. So it should be no problem to always to have the drug at home. But when the doctors check the drug adherence by recording the medical procession ratio, it was shown that there is impressive proportions of patients who do not have tablets when they need them. And this correlates well with the adherence. If the adherence is high, if the patients always have tablets at home, they have a good outcome, but the probability of overall survival declines dramatically in those who have a poor adherence. So you should prescribe always as 2 packets of tablets, one as reserve, and especially problematic are children with divorced parents where the child visits the father, for example, at the weekend, and then the father also should have a reserved package at home for this situation. This next slide sounds trivial, but a drug that is not swallowed will not work. You see the doses here, and if smaller children are not able to swallow tablets, you may disperse the tablet in a glass of water or in apple juice, and once the tablet has dissolved, the whole fluid must be drunk. You can also use crushed tablets and like imatinib and nilotinib, or you open the capsule of Sprycel and release the powder to apple puree or yogurt, but also only to a small amount, because the whole puree and the whole yogurt must be eaten to get the correct dose. The obstacles concerning the patients is at older age an insufficient body perceptions. There may be wrong beliefs or wrong treatments, especially in rural areas, but also with academics. There are sometimes some magicians or voodoo treatment. There may be, especially in teenagers, a depressive coping, that they mostly girls feel hopeless and helpless, and you have to unravel these situations early to seek help, maybe from a psychologist if available. And a passive attitude, not actively fighting the disease, will lead to psychological repressions, or the opposite, neglecting the disease and not taking the tablets. And in some countries where the parents have to pay for the tablets, the family may feel uncertain about the social situation, whether they will have to sell their house to afford a lifelong treatment. The social and political conditions is a hard topic to talk about for me, because it's different in all countries. But concerning the family, also it is important that the family members, especially the brothers and sisters, give big social support. And the same holds true for friends, or at school, or at work. There may be hindering structures and institutions that taking tablets is not possible, but from my experience, that is a exception. And the same holds true for hygiene management, because special hygiene measures are only necessary when the white cell counts drops very low, which is an exception happening in CML only during the first 3 to 6 months of treatment. The access to medication differs a lot. It depends on the insurance companies and on the health authorities who is going to pay for the tablets. And this is a broad range from countries like in Germany or Korea, as I showed you, where the insurance is guaranteed by the government and the costs are covered, to countries where the tablets have to be paid by the parents to 100%, and sometimes are not available in the drugstores. But also social and political, social conditions comprise that there should be an open attitude to the disease, that within the family and with friends and colleagues, there should be talked about the disease and how it's treated, and that the expected outcome nowadays is that a normal life can be led, and that the age when the older patients will die is the same as in the average population. So this is really a big success of CML treatment, but this must be clearly communicated. The another obstacle is the relationship between the patients and the physician. There may be hierarchical structures where the relationship is not based on partnership. And that may be due to lack of time to talk to the patients, but also may be a consequence of the self-model of the physician's role. In pediatricians, I think this is rarer than with other areas of medicine, but you should always be a partner when talking to the patient, and the same holds true for the other medical staff, which should be emotional supporting to the patients. And there may be missing confidence, bilateral, that the doctor says, what I recommend, this girl will not follow my advice, and mother and girl think this doctor knows nothing about CML. And this might be true in the beginning, because in an average scenario, there is one patient every 2 to 5 years only. And this might well be the first patient you are treating, but then you must get informed about the disease, and you must gain competence to talk. In CML, the responsibility changes by time. During the course of the disease, in an acute disease, the physician almost is responsible that the appropriate treatment is selected, and by time, in a chronic disease, the patient and the parents take over. So this division of responsibility must be acknowledged, but it also must be checked at certain time points that the patients adhere. So in this relationship, the communication should not be one-sided, and it should focus on the patients, and the patient's questions must be answered, and there always must be a feedback from the patients, and lack of time should not result in insufficient information on the disease of treatment. The treatment itself as a last obstacle means that the rating of the therapy by the patients may be rated as painful, stressful, bothering, or too complex, which hardly holds true in CML, except if there are some complications where several tablets must be taken. But most importantly, there is no immediate benefit of a long time treatment. And that is hard to be acknowledged, especially by teenagers. And there may be a growth delay by treatment, which is not dramatic. It's always within the normal range of the percentiles, but the younger sibling may overtake in body height the treated patients, which might be psychological problems. Other side effects must be reported early and then treated, and it may be necessary to change the drug to avoid these side effects like rash or edemas. There might even be fear when you change the tablets because of side effects. And also older children will well memorize the illness caused by side effects. For example, a rash or painful muscle bone pain during the night. So again, this requires a lot of talking to explain that it is worth trying, and that there is always another option to manage these side effects. As I told you before, I prepared material to transfer this knowledge, and I found this always very helpful. And I want to give you an example on monitoring MRD as final slides. So the illness in CML here is shown as the attack of a sea monster, which dives up from the ground and attacks the people in the boat. And therapy might mean you fight the monster by hitting it with the paddle. This is an example well liked by boys up to the age of 6 to 14 from my experience. And the attacked monster then will sink down to the ground, and hopefully it will stay at the ground or will even die. That means treatment-free remission. But there is a possibility that the monster survives and shows up again at the top level of the sea, and the attack begins again. So you have to measure the depths where the monster is, and you can do this with a paddle, which has a limited length. That is the microscopic technique, but you can bind two paddles together. That gives you a deeper probe, which represents cytogenetics or PCR. And so this rather complicated techniques might be explained in easy words and examples so that patients will understand why this monitoring is necessary. And this brings me to the end of my talk. Most I learned is from my patients, and if possible, I highly recommend meetings of families affected from a child with CML, where there is intense exchange of knowledge and of ideas how to handle the disease. I thank you for your attention. Bye-bye.